All right, welcome to our live stream at Duke Spine Institute. We're getting ready to perform a Duke laser disc repair at C5-C7. Our patient was basically a professional football player. I won't go into details, but he has a very thick neck, and I had some concerns about being able to access the disc. We were able to do so at C5-6. You can see on the x-ray, we've put a little dye in there. Yeah, Jordan is going to show us. Can you see the x-ray there, Henry? A little bit of dye extravasated anteriorly behind the pharynx. Show us the esophageal temperature probe. There, trachea, endotracheal tube there. Spine, good. C2, 3, 4, 5, 6. So we're at C5-6. We got a needle in there. A little bit of dye. Let's go lateral. Or sorry, you were going to do AP. I apologize. Go ahead and get an AP shot. All right, looks good. So you can see the needle is entering the center of the disc. There is dye in there, but not much. See if I can do a little more. All right, so with the Duke laser disc repair, it's anterior from the front, transdiscal, meaning we're going through the disc to get to the back where the herniation is. Shot. All right. Just let's try to advance the needle a little bit more. This is a very tough case to do. I actually told the patient ahead of time, I said, there's a chance I won't be able to do your surgery. I'll try my best, but there's a chance I won't actually get it. So you always got to be prepared for that. Shot. Well, let's try one more. Hold on, let me have the shoulder. Shot. Well, I don't think we can do any better with the dye. I really don't. It's just there's so much scar tissue at the back of this disc, it's blocking it from going back there. So we're just going to have to place our guide wire. We're going to need to do another shot. Somebody's hand's in the way. Shot. All right, so let me show you how to do it. You don't grab it. You take your hand on the ball and you push in and down. Shot. I guess you have to grab his. Shot. All right, that's better right there. His shoulder is just too high on that side, so you got to grab the whole shoulder and pull it down. But you don't have to grab it at the ball. You can go below the ball. That looks good. All right. So we're going to make our skin injection and then skin incision. So we can definitely get C5-6. And I'm hoping and expecting to get C6-7. Our last patient that did the fusion, he's doing well. No problems. And he's just having pain. He's going to be ready to go home in about 30 minutes. The incision for this surgery is about 4 millimeters. Our patient clearly, to me, it appears he is on some kind of a blood thinner. Something is thinning his blood. It's not terrible, but there's definitely, looks like, some residual effects. All right, shot. Very nice. You guys are doing great. I think we're okay to proceed. It's minimal. It's not under pressure. It's just a little bit of capillary ooze, we call it. Capillary ooze is not a problem. Stops with a little bit of pressure. Hold on. Shot. Beautiful. See guys, that was the problem the whole time. That left shoulder was just too high. He was catawampus on the table. You know what I mean by catawampus? Like this. That's the problem. We just needed to drop that shoulder and we're fine. Because we got the preoperative x-rays and they look great. 2, 3, 4, 5, 6. Beautiful. I think we're going to be able to get 6, 7 I feel good. All right, I'm at the front of the disc, front of the spine. And let's get an AP, see, make sure we're in the middle. Coker. AP, for those of you who don't know, is a anterior posterior view, front back. We've been doing side views. Let's get a front back. Oh, perfect. Look where the tip of that probe is. It's dead center. Right there, yeah. And the guide wire runs off to the left a little bit. All right, thank you. Back to a lateral view. Any questions from our audience?
No current questions.
All right, great job, guys. Stay with it. I'm almost done. Shot. Let's just go with a mallet. Shot. Perfect. Just a little bit further. I feel the scar tissue. Oh man, it's bad.
It's reverberating.
You feel it?
Fast
Yeah, you feel it too.
Yeah.
Oh man, it's
Yeah.
really thick.
Well,
Let's try a little pipe cleaning, and then let's try another discogram. I want to see if I can get anything past this massive wad of tissue. Shot. Oh, you guys. Yeah, sticky. Shot. Shot. Just can't see anything. All right. Well, we see enough that we can proceed safely. Crazy, huh?
ready, Oscar?
We have the MRI over there. It's very odd. Shot? What do you think, Luis? A little further, right? Just a little bit? I mean, we're right there, right? I think we're almost there. We're just a millimeter away. I want to look at that MRI in a moment. 4 millimeter tube. We're going down to the disc. We'll go through the disc along the shaft of the dilator. Now, one of the other things we've got to think about is this collarbone, shot? Because this collarbone can block the access to the disc at C5-C7. I've just got to see whether or not we can get down there. Right now I'm being optimistic. I think we can, but we won't know until we get a little further along. Shot? Beautiful. All right. We are making progress. New tube.
Yeah.
All right, I need inline traction,
Ready?
and I need a good view. Shot?
A slight extension?
Slight extension. Shot? Uh-huh. Shot? Man, just there's something very hard in there. It's not calcium, but it's shot? Scar tissue, or I don't know. We're right at the back. I think I can work with this. I want to try to get a little bit further. Shot? Shot? You guys are doing great. Yeah. That's it. I can't get any further. Just give me a little more inline
Okay.
so I can get this out, because
Sure.
I feel like the disc is clamped down.
Let me.
Thanks, guys. Let's get the fluoro out. Did that tube shift at all? Let's just see what we got. All right. Nice job, Luis. Definitely not easy. All right, let's put our our scope on. Scope on.
Hold on, please, for the steering. Thank you very much.
We're not out of the woods yet. It's really incredible how firm. Good news, we have a little bit of dye down here. I need this out of here, please. Should not be there. Where's my pedal? All right, good. There's a piece of herniation. There's bone spur.
Oh, that's okay.
Could be bone spur. Yeah.
He's had this for a long time,
Yes.
and he has a job in a lot of rotation, he said.
Yeah. Being a football player at a professional level, I guess they do. Well, it's still college pro. Pretty close. Don't want to take away from the pros, but yeah, he's got some pretty bad spurs back here. Look at that. Very interesting. Well, he's definitely taken a beating as a professional athlete or a semi-pro athlete with his neck. Man, you can see there's a lot of bone spurs. A lot of bone spurs. Honestly, even more than I expected him to have.
He mentioned he had multiple concussions.
Multiple what?
Concussions?
Concussions?
So that's the axial load right on the
Yeah. Sure.
That's what ended my son's football career.
Is that right? Your son was a football player.
Yeah.
What did he play?
He was a slot receiver.
I'm sorry?
Slot receiver?
Receiver. This is pretty bad. People ask about bone spurs. Yeah, this is one of the most bone spur-full spines I've seen in a long time. Everything is calcifying. Doesn't mean it's fusing. Don't mistake that for fusing. It's not fusing itself. It's just calcifying.
We have a question.
Yes.
This comes from Samir on YouTube.
Hi, Samir.
They ask, do you remove osteophytes when removing herniations in the cervical?
Samir, we're taking osteophytes right now. All of these things are osteophytes. That's what he has mostly is osteophytes. There's herniation and osteophytes, but a massive amount of scar tissue from injuries a long time ago. This is all scar tissue and osteophytes right here. This is one of the worst cases I've ever seen. As a matter of fact, but I still think we're going to be able to help him with this surgery. This is herniation right here. It's just, see how scarred it is and how it's turning gold in color? That means that it's got lots of calcium in it. I need you to help me here. Forget about that. Push the chest. Yeah. I'm having a hard time reaching back because his chest is so barrel big and it's blocking my scope. Yeah, we've removed osteophytes in many spines with a laser. But the amount of osteophytes we see typically is not this much. This is really, really bad. Probably related to his football injuries over the years to his neck, if I had to guess. So what this indicates is a lot of inflammation happening back here. Remember, this is C5-6. There's a piece of herniation there. More osteophytes there. This is all osteophytes I'm taking away. All right. Let's show our audience why do disc injuries in the neck cause so much pain in some patients. All right.
Traumatic injury on the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissue develops within the annular tear, causing neck pain. The inflamed annular tear generates pain signals. Additional injuries can cause worsening symptoms. Inflammation from the annular tear can spread to the nearby nerve roots, causing arm pain. Pain signals travel up the nerves to the brain, causing localized neck pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of neck pain. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at www.mri.dukespine.com.
All right, now you understand why these herniations cause so much pain. It's inflammation, and inflammation over time, a long time, leads to bone spurs like these. These are ginormous bone spurs here, and I've been whittling them down with a laser, all of these, and some of them I had to take out, some we don't have to, we're going to leave because they're not safe to remove or they're not causing symptoms. But this is herniation right here. All right. Wow. That's why. He's got a lot of bone spurs. Had a lot of damage over the years to these discs. I think it's more related to his sports that he plays. But you see how the laser can easily remove these bone spurs. Okay. I'm going to flip to the other side. We're going and looking in his left arm now. Left foramen. Thanks, Luis. Massive amount of scar tissue here from his herniations over the years. And this is pressing up near the spinal cord. So I'm going to try to remove as much of the scar tissue or herniation I can. I've gotten most of the herniation out. Probably about 80% of it. What's left is some bone spur. There's some more herniation right there, just off to the left side. Again, this has been around for years. I don't know how old his symptoms are, but all of these pieces of herniations are at least 20, 30 years old. So I don't know if he's had these symptoms for that long. You know, a lot of people can't tell us how long they've had their symptoms, but I can tell you this injury is at least 30 years old. It's pretty bad. Any questions from our audience?
No current questions.
All right. I'm going to be done with this level in about, 8 minutes, I believe. Berndes, how's he doing?
Fantastic, great vital signs.
Great. Good to hear. Patient's doing well.
Everyone's doing well.
All right, let's take a look back across to the other side. A lot of, see the blue herniation here?
Yes, we do.
Little bone spur there. I got most of that already. Pretty happy with this side. I don't see any more herniation. Gotten rid of a lot of the bone spur. Some of this is going to be not possible to remove safely because it's resting on the spinal cord, and we can't take everything off of the spinal cord. Definitely has a little bit of ossification of the posterior ligament. You can see it there. Let's go back out the foramen. It's interesting. What he must have had happen was he must have had this long-standing problem, and then he got some acute herniation like on top of it, you know, because this has been around for like 30 years. This is not new. This has definitely been around for a long time. You could see it. It's old injury. Probably traumatic if I had to guess from his football career. All right, let's see. I don't see anything more. There's a little bit more right there. This is all on the left side where he's having his arm symptoms. So I'm going to remove this. I hear it too. I think we're okay. All right. 1 minute. Done just about everything I can on this left foramen here at 5-6. I don't see anything more back here. So
Lights on, please. Thank you.
let's hope that does it for him.
No, just this one. This one right here. Thank you.
Going to irrigate out any pieces of loose disc material back there. Did you pipe clean this? All right. All right, at this point, I'm going to try to move down south and get the next level. This will be the hardest part of the surgery. I do need that step up. Just till we get in. Thank you.
Can I get a towel? I'm getting sweat over here. Thank you.
All right, it's going to take our concerted efforts. I do need a head inline traction. I'll need a shoulder pulls, and I'll try to do lateral, but I may have to go just with AP. All right. Whenever you're ready, Dr. B.
All right, I'm ready.
Shot?
All right.
All right. That looks good. Just stay there for now. The AP view is not the problem. It's the lateral view, as always. All right, that's our picture there. Yeah? See if you can clean that up anything, Jordan. That's, if I could just see the disk space below, that would be perfect. Almost there. I think we're pretty close. Any way to mag it in? Maybe zoom it in? Maybe bring it, the emitter closer? Yep. And shot. That's pretty good. I think I can work with that. I can work with that. All right. We're going to move south. The question is, will I be able to do this with this clavicle in the way? Shot. I'm coming up. Almost out. I will want to get an AP at some point. And we are out. All right, so let's get an AP, quick AP. APs aren't bad, they're easy to get because the shoulders aren't in the way. And then I've got just a few millimeters to go and we'll be in the next disc. Perfect, let's go back to a lateral. Same lateral view you gave me last time. So I'm right in the middle. That's it right there?
Yes, sir.
All right, can you clean up that disc? Just give me your best disc. There we go. I think that's better, right? Yeah? I like it. Let's try this. I'm going to move south a little bit. Don't move, guys. Shot. Very hard to get there. Shot. Just a little bit. Let's get another AP, make sure I'm still in the middle. I don't want to come off to the side. That looks good. We're almost there. Poor man. It's not easy. This is probably one of the hardest ones I've done. Shot. Just about there. We can just get a tiny bit more. Shot. I think we're there. We just got to now see if we're in the AP. Where are we in the AP? So everyone stay where you are. Don't move. Man, that's really hard. I don't know that I can get that. I'm going to try. I'm feeling a lot of clavicle resistance. All right, we're good on the middle. So I'm right over the disc, but I'm really having a fit trying to get this down here. I might get it. Shot. That looks really good. Mallet. I'm going to try to anchor and pin the tip right in the front of the disc. Shot. All right. Well, I'm getting some resistance though from his clavicle. That's the problem with these thick necks and high clavicles. Shot. If I just cannot get this lined up right, man. Shot. I'm maxed out right here. I just can't do anymore. Shot. All right, let me think for a moment. Let's have the tube. I'm going to try to bring the tube down, see if that can help me just a little bit. I need a little Raytech. So I'm not letting the dilator come up, keeping it where I need it planted inside the disc. I'm going to try to bring this tube down. Shot. It looks like we're just inside that disc, which is good. Luis, will you hold this dilator right there with 2 fingers? Hold it, yeah. There we go. Let me try to bring the tube down. Shot. Almost there, actually. Yeah, we're pretty much there. Hold on. Yeah. Let's try that. The whole unit together. Might be able to get it in there. Give me some inline traction. Yep. Shot. That's better. That's putting the tube in. I need to get the dilator in. No, take that off. Shot. See, I'm having the same thing with that bone right inside the disc. Shot. He's got the same problem here. Shot. Any way you can clean that up a little bit? I need it cleaned up just a little bit more. It's not any better. Looks like we're just along. Huh? Skiving. But the problem is I can't get the angle I want because this clavicle is right here. It's forcing me north. But that's not terrible where you are there, Jordan. I just think we're hitting that same material as we did last time. Shot? Well, I don't know. What's that? Is that my hand in the way? That looks like my hand in the way. Shot? What do we got? Let's have some irrigation. Maybe there's a little bit of dye. On the pig. That helped. Yeah, that's the problem. I'm right at the mid vertebral body end plate, and I'm struggling to get it pointing up, you know? All right, let me just see that. How's that? It's close. Maybe enough. Huh? Give me a little extension.
Okay, little extension.
Shot? Yeah. Shot? That's about a, it's back there. We're there. We made it. Shot? I can't believe it. We did this. Shot? Right? I just can't believe it. We're almost there. I just want another millimeter. Damn. All right, let's bring the tube in. This is just a struggle. Mm-hmm. Shot. I feel the tube sliding. Shot. Give me that inline traction, Berndes. Come on. It's not the time to quit. Shot. Almost there. Shot. I feel it moving. Definitely making progress here. Shot. Can't believe it. Let me put the dilator back in. It's the hardest I've ever done. Shot. Hold on now. Hold on. Shot. All right. I felt it go another millimeter. Well, let's try this and see where we are, what we got. I felt like we're back there. Take it out. Little interaction. Good?
Yeah.
All right, folks, what's happening for watching? See this right here? Look at that. We're fighting his clavicle. There's nothing we can do about that. That's his collarbone. I can't get any further down. This is the best we can do. Is it good enough? We won't know. Won't know until he wakes up and tells us, my God, that's really, we're going to have to make it quick so that we don't get any issues with the skin. Luis, will you help me by?
Yeah. What do you need, sir?
Nothing.
Holding the
Let's get the irrigation on.
irrigation, please.
Irrigation on here. Yeah. We don't have the benefit of any of our blue dye either. What happened?
No.
You okay?
Yeah.
I need my pedal. Got it? All right, let's go on. There we go. Good. Well, we're definitely in the disc. Same story. Lots of bone spurs. A lot worse. Huh?
The yellow white shining.
Yeah. Man. Is the laser on? Yeah. Let's flip it. Same thing. Same thing as that last disc, guys. Just horrible spurs. Horrible, horrible, horrible. Yeah. That's crazy. Well. Yeah, is he still relaxed? Hey,
What do you need, sir?
I just need the shoulder. I'm trying to get the clavicle to go down a little bit. There's a big herniation right there. See that? Get these pieces out. So I see a lot of calcium, but I also see a lot of,
I could give him some more.
I don't know.
Okay.
I don't know how much it's gonna help.
That'll last 50 minutes.
Yeah, these are just pieces of herniation coming out. almost wish I had the lumbar scope. You know?
The short one that we use for the.
Unfortunately, we didn't get any dye in this disc, so we didn't get to stain it blue. So you can't really see the herniation, but that's it. It's just white. Yeah, almost. So scarred. Look at that. That's the hardest I've ever worked to get a herniation. I think that's the hardest Luis has ever worked. Am I right, Luis?
Yeah, you're right.
Let's have a grabber. I want to see if I can grab some of that right there. That's a herniation for sure. This 6-7 was the worst of the two. 5-6 was older. Of course, the hardest one has to be the one that needs the most attention. I've always wondered how dentists can get in your mouth and work on all your teeth, and I've always been amazed at that. And right now I feel like I'm struggling here, which we are, but we are making progress. I gotta say that. Every little bit we take out is a little piece of that herniation that is causing symptoms. And honestly, we're just millimeters away. There's pieces coming out. You guys see them flying out? That's good news. Every piece we get gives a little more hope. Being a football player is wonderful until you have to have neck surgery, right? Then it's not so wonderful for your surgeon. That's as much as I can do.
Lights on, please. Thank you.
Oh. I feel like we got probably 50%. I'm pouring in sweat. Oh yeah. I can't do anymore. I think that's going to help. I don't know if it's enough. We'll find out. It's definitely the most I can do. And that was the hardest I've ever done. We pulled out all the stops on this one. All right. Honestly, right up against that collarbone made it so hard. All right, any questions?
No current questions. We just have a comment from Canes25, who says, what a surgery that fusion was. Nobody does it better.
Oh, I'm going to tell you something. That fusion we did was easy. Like scale of 1 to 10, 3. Compared to this. This is on a scale of 1 to 10, it's a 15. This is as hard as it gets. There's nothing harder.
I've never seen Dr. Duke sweat in the OR.
Yeah, I'm sweating. I'm sweating. All right, looking good. A little bit of venous bleeding. We'll put some pressure for a few minutes and then it'll be fine. But basically, the difficulty here was the collarbone, and he's a former football player. His collarbone is here, and man, that thing is strong. And I needed to get this angle to get to 6-7 and get the whole disc, and the collarbone kept me from coming down. So we were always fighting the angle the whole time, but I think we definitely got 50%. Is that enough? I don't know. We'll just have to wait and see. I hope it is. The good news is that if the disc heals up properly after surgery, which I expect it will, and we get enough of it, that he's going to have good relief and it won't come back. All right, I'm sorry we didn't comment very much, but this was honestly one of the hardest I've done. And I'll come answer questions in a few minutes. Just going to put a little more pressure. I think he must have been on something like ginkgo biloba, or I don't know what he's been on, but he's on something that is making his blood not want to platelet. Huh? Yeah, we went through his medication list and everything, didn't find anything, but he must be taking some kind of supplement. I don't know. He'll be fine. Just keep pressure on that for a few more minutes. You got time anyway, Luis, because he's got to reverse him. And then once you get it dry, let's put a bandage with a little bit of pressure. It's very mild. But I think it's going to stop in another minute. All right. Bit of a disappointing case overall.
No stitch or a staple or anything, Dr. Duke?
No. We don't want an accumulation. All right, Henry. Why don't we just end this one?
Copy that. There are no current questions.